We've been talking about what happens when the anterior pituitary doesn't do its job well. Hypopituitarism, in other words. In this sketch, we'll get into all the crazy stuff that can happen when the anterior pituitary does its job too well. Anterior pituitary hyperfunction is the name of the game. And this time, we'll dive right into the clinical presentations of having too much of each of the flat pig hormones: FSH, LH, ACTH, TSH, prolactin, and growth hormone. So, scooch in closer, kids. Put on your imagination caps, close your eyes, and hop aboard a magic spaceship powered by a fuel made of wishes and dreams and imagination and ground up unicorn horns. What did we do with the rest of the unicorn? Oh, well, aren't you inquisitive? Story time. Pay attention, everyone. The most common cause of pituitary hyperfunction is a hormone-secreting pituitary adenoma. Sounds kind of familiar, right? It should, because at the beginning of the chapter, we saw how an adenoma can cause hypofunction of the pituitary. Imagine that the big, bulging pocket on the side of that pituitary-shaped book bag is an adenoma, a big mass of cells putting pressure on the gland, and before you know it, the pituitary gets necrotic under all the pressure. So while pituitary adenomas are usually benign, remember that benign does not equal harmless. Let that boxing poster on the bedroom wall remind you of our pituitary knockout sketch, where we illustrated how adenomas that grow large enough can cause symptoms such as headache, bitemporal hemianopsia, hemorrhage, and loss of pituitary function. Well, this time, on top of all the usual symptoms, these adenomas also happen to secrete hormones. Yep, this isn't just a mass of books. It's a mass of stories. Secreting imaginary tales of growth hormone giants and prolactin-infused lactating man boobs. It's more exciting than it sounds. Sit back down. Besides a good old-fashioned sporadic adenoma, hyperpituitarism can be associated with various syndromes that are commonly tested on step 1, but rare. For example, multiple endocrine neoplasia type 1 syndrome is characterized by the triad of hyperparathyroidism, pancreatic islet cell tumors, and pituitary adenomas, the 3 Ps. As a reminder of Men 1, we've highlighted the 3 Ps and the number 1 grandpappy sweatshirt. Additionally, McCune-Albright syndrome can be associated with hyperpituitarism, which will be embodied here by the Albright booklight. McCune-Albright is caused by a spontaneous somatic mutation in the early zygote. As the embryo develops, the mutated cell proliferates into many mutated cells throughout the body. This can lead to genetic mosaicism, which means that 2 different populations of cells with different genotypes are found in a single individual. The affected cells contain a mutation in a gene that controls a G protein signaling pathway, which leads to increased cyclic AMP activity and overstimulation of endocrine tissue, including the pituitary. Endocrine overstimulation results in a classic triad of clinical manifestations. Look for café au lait macules on the skin, which are often unilaterally distributed, hence the unilateral coffee stains on the book. Also, the overproduction of pituitary sex hormones like FSH and LH can lead to precocious puberty. This can show up as vaginal bleeding, enlarged ovaries, and accelerated growth. An excess of growth hormone can even lead to gigantism. The third part of the triad is fibrodysplasia, which usually affects multiple bones. Other endocrine abnormalities include Cushing's syndrome and thyrotoxicosis. All kinds of stuff. But I digress. The main topic of this sketch is functional adenomas of the pituitary gland. The most common functioning pituitary adenoma is composed of lactotrophs, or the cells that secrete prolactin. In premenopausal women, hyperprolactinemia can cause milky nipple discharge, also called galactorrhea. Also, you see how the overload of prolactin bottles is tearing apart that GnRH bag? Prolactin acts directly on the hypothalamus to inhibit GnRH release. This, in turn, leads to decreased FSH and LH secretion by the pituitary. At Sketchy, FSH and LH are symbolized by the flower-stimulating fertilizer and luteinizing greenhouse lamp. FSH is like a fertilizer that lets follicles in the ovary grow, while LH is like a spotlight that shines down and chooses a single follicle to fully bloom, rupture, and release an ovum. Notice that we've knocked them both over, however. And at the gonadal level, this results in decreased levels of sex hormone, i.e. estrogen and testosterone, which can lead to symptoms of hypogonadism. This includes amenorrhea, depicted by the spotless white shirt, and infertility, symbolized by our recurring infertile uterus tree. Postmenopausal women, on the other hand, are effectively hypogonadal already. So hyperprolactinemia tends to not present with many specific symptoms until they grow large enough to cause neurologic symptoms via mass effect. In men, hyperprolactinemia and secondary hypogonadism leads to decreased testosterone secretion and, in turn, those classic symptoms of impotence, infertility, and, rarely, galactorrhea. Treatment of prolactinomas may include surgery depending on the size of the tumor and the patient's symptoms, or pharmacologic therapy with dopamine agonists, such as cabergoline and bromocriptine. Surgery kinda goes without saying, so we've decided to illustrate the interesting ones, cabergoline and bromocriptine. Represented by this cute plushy cabergoline burglar with special edition bromocriptine broom handle knapsack. Both of these agents are D2 dopamine receptor agonists, symbolized as usual by the D2 double dopamine rope. D2 receptor activation directly inhibits the prolactin-producing cells of the adenoma. It's the perfect reminder of pituitary physiology. In a normally functioning endocrine system, the hypothalamus secretes dopamine onto the pituitary to inhibit prolactin release. And we're taking advantage of that effect here. After prolactinoma, the second most common functioning pituitary adenoma is one that produces tons of growth hormone. This is an exciting one, by the way, because it takes place in the land of giants. At Sketchy, growth hormone is symbolized by growing beanstalks. And you see those large vines growing through that liver-shaped hole, right up into the giant's abode? Growth hormone heads to the liver and activates the release of insulin-like growth factor 1, or IGF-1. At Sketchy, our symbol for insulin is a welcome inside mat, emphasizing insulin's role of bringing nutrients inside the cell. But once combined with our growing vine symbol, it should remind you that this isn't insulin. It's a molecule that looks like insulin. It turns out that many of the growth and anabolic effects of growth hormone are actually mediated by IGF-1. And you should expect both growth hormone and IGF-1 to be elevated in patients with a growth hormone secreting pituitary adenoma. As an interesting little quirk, up to 30% of growth hormone secreting adenomas also secrete prolactin, which can lead to all the symptoms of hyperprolactinemia that we described earlier. But what about excess growth hormone and IGF? Well, increased levels of these hormones are floating around in the blood before fusion of the epiphyseal plates. This leads to rapid linear bone growth and extremely tall stature, also known as pituitary gigantism. We'll start our discussion in adulthood, however, after the epiphyseal plates close. At this stage, linear bone growth is no longer possible. So instead of gigantism, excess growth hormone and IGF-1 leads to acromegaly. Most patients with acromegaly are diagnosed around 45 years of age, but may have had the disease for many years due to the slow growth of the adenoma, as well as the subtle changes acromegaly can have on physical appearance. One of the most prominent features of acromegaly is nonlinear bone growth, leading to increased jaw size, or macronathia, frontal bone bossing, and markedly enlarged hands and feet. Soft tissues become enlarged as well, leading to macroglossia and hypertrophy of oropharyngeal soft tissues. In some cases, upper air soft tissue hypertrophy can lead to obstructive sleep apnea. Thickening of soft tissue also leads to thick, leathery skin in some cases. Other facial changes include increased hair growth and even hirsutism in women. Synovial tissue can hypertrophy and become less flexible, leading to arthritis, or more specifically, hypertrophic arthropathy. Organ enlargement, or visceromegaly, also occurs, affecting the heart, liver, and thyroid. Everything's just big. Patients with acromegaly also have increased incidence of colon polyps and cancer, especially in untreated or undertreated cases. Patients with acromegaly usually have hypertension as well, hence the high-pressure steam coming out of the giant's ears. Both growth hormone itself and increased insulin levels cause sodium retention in the kidneys and increases in plasma volume. All this increased pressure can lead to left ventricular hypertrophy, diastolic dysfunction, arrhythmias, and even valve disease, especially aortic regurgitation. As you can guess at this point, cardiovascular disease, especially heart failure, is the most common cause of death in patients with acromegaly. Growth hormone also boosts lipolysis and gluconeogenesis, resulting in hypertriglyceridemia, glucose intolerance, and diabetes. Which sounds bad until you realize each one of those sugary candies is like the size of a man's face. Worth it. Because of the cyclic nature of growth hormone secretion, it's actually easier to measure IGF 1 out in the circulation.